Welcome to this tools and techniques session dedicated on optimizing treatment for patients with severely calcified lesions, the role of orbital atherectomy. You might notice that I'm going slowly to get you with me connected. Thank you very much. That's a tools and techniques session, a very practical session with a live case demonstration from Madrid, Spain, sponsored by Abbott. So thanks to our sponsor to make this possible. Let me give you some more details about this session, if we can have the slide on the screen. This is the team we are working with today. My name is Emanuele Barbato from Rome in Italy. My spokesperson, or co-chairman as we like to call him, is Evald Christensen from Denmark. To my right, expert panelist Florim Tsutsuli from Switzerland, and then Peter O'Kane to the other side from UK. The team of operator in Madrid will be Javier Escaned and Nieves Gonzalo, and our medical coordinator is Jeremy Boyer, or Boyer en français. This is an interactive session, so as soon as you are done with your lunchbox, help us in doing this case, either through the EuroPCR mobile app or taking one of the standing microphone. I think we are right to have a look at the clinical case, Evald. They selected for us.
Thank you very much. I have the honor of introducing you to the live case that is set up for you today. The case is a 73-year-old male, ACX, in the context of respiratory infection. He had effort angina up to this event. He had COPD and a recent COVID infection. Conventional known risk factors and ACS with only mild troponin elevation. He was independent in daily life. He was an active person and on now dual antiplatelet therapy, conventional drugs, and some treatment for the COPD. Hemoglobin and renal function, nothing to mark, and the troponin was slightly elevated. The left ventricular function was normal, there was no valve problems, and he was in sinus rhythm. This is the angiographic shot from the left. What you can see here is a calcified lesion in the proximal part of the circ and a very high takeoff of the first obtuse marginal. Other projections showing disease all the way up in the ostium of the circ. And some changes in the LAD and the left main, but not very significant. You have different projections here, and the right was without significant disease. So this two bifurcations led to an intermediate syntax score of 27 and an estimated syntax 2 score for 4-year mortality with PCI 10.2 and with CABITS 30.4. So the recommendation from the heart team was PCI, also due to a very low bleeding risk estimation. So the decision was PCI, and I will hand back to Emmanuel to take over.
Thank you very much, Evald. So, 73 years old, recent acute coronary syndrome in the context of a respiratory infection, severely calcified ostial circumflex stenosis, in brackets there is also the specification calcified nodule. It's a challenging case. Florim, I think the first need to agree upon is whether this is simply an ostial circumflex stenosis, quoted and quoted, or it's a left main disease, because this will change completely our strategy. What do you think?
I mean, I congratulate the operators that they chose such a case, because it's a really challenging case. To be honest with you, at the moment, the question if this is purely an ostial problem or it's a left main problem, I don't know. I cannot tell from this. I suspect that this is actually a left main problem, that we will end up treating the left main. And of course, having so much calcium in ostial circumflex, and I'm sure we'll come back to that point later, is especially challenging. So this brings to my mind that in order to have more information, we need to image this.
Hold on, let me pitch also Peter's opinion. What is your guess about this lesion, Peter?
Thank you very much. I agree. I echo those thoughts. It's a very complex case. Calcium, tortuosity, and quite an angle from the left main stem. For me, I think imaging is a key component of this procedural case. And I think the imaging that I would probably want to use, because I'd like to have more definition from the calcium perspective, is OCT. But there may be some challenges in delivering the catheter.
Allow me to do something I'm not used to do, that is to involve really our colleagues in a very time-by-time fashion, also to disturb them while they're eating. Do you agree to use imaging to start with, or would you start this procedure just on the basis of the information you have? So I will pose again the question by show of hands. Who's happy only with angiography and can go on with this procedural plan? Raise hands. Who can already start with angiography? Who needs imaging to go on? And when we speak about imaging, who would like to do intravascular ultrasound? Raise hands. Who would like to do OCT? Raise hands. Both hands. You raise both hands. That's not fair. Okay, so we heard what I thought. You cheated, so I'm going to Peter, to the other side. Peter, you heard what they shared with us, the colleagues. They want to see imaging. They are actually split between IVUS and OCT. What do you think? One can give more than the other, or they are complementary?
Well, it's a great question. I think the key is imaging per se. So once you've decided that imaging is essential, the different components, different modalities do offer different experience. I mean, IVUS may be technically easier in terms of if you're trying to treat osteal disease, but we know from the October trial that eval clearly led with Niels that actually OCT is very feasible. The benefit here for OCT for me is the calcium definition and the understanding of what tools to use in the case. And even up front, if you can't get it around the circumflex, even just imaging from LAD back to left main, I think will provide a lot of information as a starter.
Florim, I don't want to dismiss you. I still want to hear your opinion. IVUS, OCT, are you optimistic that we would manage to take this angle across this lesion?
Yeah, that's a very good question. Sometimes you are surprised that you have a very tight stenosis and still you can manage to cross your imaging device. In my opinion and in my practice, I would probably go for OCT instead of IVUS. The reason of that being that I really want to have a higher resolution and see two things. First, how the calcium is exactly distributed and how thick it is. And second, I would like to know, the presence of nodules and really appreciate this, because that would influence a lot my strategy, how I treat this. Now, if you cannot cross your imaging device, that's always a challenge and it can happen. Then I'm still happy to do some work up front and still be able to image before I really go to the procedure itself.
That's actually fair enough. Now, let's move a step forward and let's start reasoning and brainstorming on the procedural setting here. Now we are in the treatment mode, and I would like to pitch the colleagues here. Use your iPhone to let us know what would be your guiding catheter size. That's what I want to hear from you. Transradial, transfemoral, these kind of informations. We'll try to collect them in the chat box. And next, what is your preferred plaque modification tools and techniques? Because I suppose there is a lot of calcium there. While you are reflecting and giving back to us your feedback, I will start with Peter, asking the same question.
Sure.
Access, guiding catheter size and types, and kind of plaque modification tool that you would like to adopt here.
Perfect. Access choice, I would take a 7 French system if the patient could tolerate that, because I think it gives more options, particularly when we're talking about stent strategy. And I would be using an EBU, some sort of backup guide for extra support. And I would have all the calcium modalities available on offer, because until you've got perhaps imaging or perhaps you've experienced how difficult it will be to deliver, you don't know which one you're going to choose.
Yeah, Peter is quite consistent. He says, I'll go for imaging, and depending upon imaging, I will decide the plaque modification tool I'm going to use. Let's assume you won't cross with your OCT or IVUS catheter and you are forced to do plaque modification first, what would be your choice here?
So usually in my practice, if I cannot cross the imaging device, then and it's calcium, then I'm very quick with an ablating technique. So you could use rotational atherectomy traditionally, or you could use orbital atherectomy, but I would not, in my earlier years, I was playing a lot with balloons and, do 1-0, 1-5 to 0, but I stopped doing that. I now progressively move to an ablative technique and then cross the imaging device and then continue.
There is one aspect, actually, I did not share with my team here. It's an inside information I've got from the group in Madrid. It's that this patient performed a coronary CT. It's not something I would do in my practice, but I suspect Javier and Nieves are going to discuss about this. So let's address this point now, and then we'll hear from them what do they want to share with us. Is this a patient you would take for coronary CT before doing this procedure? And if yes, what can we learn from that?
Again, a great question. We're about to embark and join Carlos on in the P4 trial, which is exactly looking at this sort of CT planning strategy to see whether it does give you a lot more information against an IVUS strategy. I think it's early days, but having been on his course and seen how valuable the information, it is very useful. And if you can acquire it in a patient without having to give too much contrast, there's no renal dysfunction here, I think it could give additive information.
Okay, let's progress. Yeah, I'm coming back to you because I have the most difficult question to you. What are the challenges that we can anticipate in this case? It's not an easy job here. But in your mind, when you are preparing yourself to do this kind of procedure, I think you have an algorithm. If A doesn't go well, I go to B. If B doesn't go, I go to C. What is your reasoning?
So maybe just, I would not do CT. I think if you have OCT, you don't need CT. But that's my opinion. And then, so the challenge is, I think the important thing are two. We need to get enough lumen in this ostial circumflex, because that's really the key of why we do this. And second is, I don't want to lose any side branch, and I would love not to end up in a two-stent strategy. So these are my thoughts at the moment.
Questions?
Yeah, there's a consensus in the audience that we should use EBU 375 and radial approach.
How did they manage to express all the same preference?
Yeah. And in addition to that, they already now discussed the modification strategy. They say rota with 1.5 or 175. That's the suggestion from the audience.
Okay, let me challenge Peter. So they expressed a clear preference for rota. The title of our session says Orbital. Mm-hmm. So what can we add more here?
Well, they could be in the wrong session. No, but on a serious note, I mean, we've been using Orbital now for a couple of years, maybe 2.5 years. And actually, when we talk about it and we've learned our experience, this is the type of lesion that we think it may be quite useful for, where you've got eccentricity and nodular formation at the ostial circumflex, where we know that any stent strategy has a higher target lesion failure rate potentially. So for me, and as an Orbital user now, I love the way the wire goes down. It facilitates easier access. The device, when you're using it, you're in a much calm environment. It's really easy to use. And I think there may be some advantages over a rota strategy in that you may be better at modifying the plaque. So for me, I would stick, I think I'm in the right session. I'm going to go Orbital.
That's a good point. Okay. I think we need to progress. We modified our plaque. Now we need to stent. We already heard from Florim that what he wouldn't like is to place 2 stents in this bifurcation. But it is important to understand what would you do if this patient was back in your cath lab. So if we can again have the light up. So the question to you is the following. Who would go with a one stenting strategy? Of course, the obvious answer would be, I want to see imaging first. Okay? I agree with you, but assuming that these are the informations you have, who would go for one stenting strategy? Raise hands. Who fears, of course nobody likes it, but who fears that we are ending up with a 2 stenting strategy? Raise hands. So 2/3, 1/3. 2/3, 1/3. Who thinks can manage this procedure just with an ostial stent at the circumflex without going backward to the left main? Raise his hands. 1. You're all alone, my friend. I'm sorry. But that tells a lot. That means that really we are quite all convinced that this is a left main PCI. Florim, we go back to you. So 2/3 agree with you, 1 standing strategy, but 1/3 is concerned that we are ending up with a 2 standing strategy. Your task will be, if we need a 2 standing strategy, how we are going out of troubles here.
I mean, there is an important point to make that I think the main lesion here is that ostial circ. So most probably if you want to solve the main problem, then you would need a stent from the left main to the circ. That's clear. Now, if you can have a taste on how this will end with lesion preparation itself. So once you are starting working, then if you see your LED starting to shut down, then you need to reconsider your strategy and then maybe move to an upfront 2-stent strategy. But if the LED with pre-dilation looks fine, then I would be very comfortable to stent left main to circumflex and then go into a kissing and end up still with 1 stent instead of 2.
Okay, good. Let's move forward. If I can have the slide on the screen, please, because I'm going to share the learning objectives. Here they are. If we are here is to learn how to identify calcified lesion in need of plaque modification, to learn how to guide lesion treatment with the support of OCT. So now you know which imaging modalities we're going to see. We're going to understand the correct application of orbital atherectomy and to share experience step by step. This is the intended procedural strategy. I say intended because the operators might change their mind as they go. Plaque preparation with orbital atherectomy, OCT assessment of calcium modification and PCI planning, management of left main bifurcation, they go for provisional, as we said, post-standing assessment and optimization with OCT. This is the interventional team, Javier and Nieves, together with their team of nurses, anesthesiologists, and the local medical coordinator. And I think we are ready to go to Madrid. Let's see if they hear us. Javier and Nieves.
Good afternoon, Emanuele. Good afternoon to everyone in Paris.
Good afternoon, Javier.
Hello.
Nice to see you on the screen together with Nieves. Ciao, Nieves.
Well,
Hello.
so sorry for my voice. I'm a victim of the EuroPCR air conditioning and weather shifts, but hopefully you will be able to follow what I have to say. In any case, I will translate most of the talk into Nieves. We've been following with a lot of interest what you have been telling us, and I must say that Peter O'Kane nailed it. We are radial approach, 7 French, EVU, and this is the scenario that we're using to start with. Now, as you rightly said, Emanuele, we in complex cases like these ones, we like to have sometimes the concourse of CT angiography, and if we can have the picture that we obtain in these patients, you will see why actually this, before having the OCT imaging, also help us in deciding. Can we have the slide, please?
Yeah, we have it here. If you give us a second, we'll show it on the screen.
No.
We have
you have it
a
there.
couple here, Manuel.
Oh, okay.
We're going to show it from here.
So,
okay.
this is what you see with angiography, and this is what you see with CT reconstruction, where you can see immediately the advantage of seeing this huge granularity, with granularity, this nodule of calcium that is located in the ostium of the circumflex, and that, as you rightly said, extends into the distal left main. Now, if we go to the next slide, we will show you what we think this was very important to understand. So this is the rationale why actually this was very helpful for us. The rationale for choosing here orbital atherectomy as the technique of choice is that with rotational atherectomy, you may expect a lot of burr bias that will be directed towards the proximal part. Here you can see it now, I think. Look at the left, you can see what will be the trajectory of the rotational atherectomy, certainly leaving untouched the calcific nodule. And at the right, you can see the alternative distinct benefit of orbital atherectomy, that is that when you're performing backward sanding, something you cannot perform with rotational atherectomy, you will be addressing this nodule and will be able to be effective. There is one additional advantage, and is the trifurcation. In the trifurcation, your bar is going straight to the carina with this large obtuse marginal or intermediate branch. So we believe that by making selectively backward sanding, we have less chances of causing damage to the carina between the circumflex and this intermediate branch. Now, I'm going to hand it to Nieves, because now you will see the possibility of correlating what we have found with the findings that you have with
OCT.
OCT.
So maybe first you can explain how was the wiring? That was one actually of the concerns at the beginning of the case, how easy was it going to be to cross this lesion with the wire. I think I have to say that the CT was also reassuring in this aspect, because we saw that there was some luminal area preserved at this level that we could probably be able to cross. So Javier crossed with a Sion wire, with a conventional wire. He exchanged with a microcatheter for the Viper wire that is already now in, you can see there the advance of, this is the OCT catheter that was also able to cross. So this is good news, I think. And I'm gonna share with you the OCT pullback. Can you go please to OCT full screen? Yeah, so first here you can see we are using now Ultreon 2.0. So we're starting from distal. This is the circumflex. And you can immediately see that it's a vessel with severe calcification. You can see a big chunk of calcium there from 9 to 12, very thick. You can see how the Ultreon system is identifying the presence of calcium and also telling us that this is thick calcium. Measuring also the thickness of this calcification is very thick calcium in this level. And now we're going to be approaching the area of the nodules. So you can see here we start with a calcified nodule. You can see there is a protrusion inside the lumen with shadow. This is the typical aspect of nodules in OCT. I have to say that doesn't look like an eruptive nodule, so the surface is quite smooth. And if we go a bit more proximal, you will see that it is the very critical area where we can see that the lumen is very, very reduced by this mass of calcium that is protruding into the lumen. This calcified nodule that, as I mentioned, and you can see it here very well, is not eruptive, so it doesn't have an irregular surface. It has a quite homogeneous surface. You will see immediately now coming the intermediate branch. And again, you can see just against the carina, as usual, the presence of this nodular calcium protruding into the lumen. And here is very clear. This is the ostium of the marginal branch, and you can see the calcium, the calcified nodule. And this is the bifurcation with the left main. So you can see here, we are now in the distal left main, where you can find there are some areas still with calcium, as expected, as we saw in CT. There is calcium also here, extending from the left main to the circ. If we go a bit more proximal, there is an area that looks a little bit healthier. For example, around this area, and this could probably be our landing zone. So regarding landing zones, we were able to identify already an area in the marginal. We saw that it's quite a diseased vessel, so we had to go a little bit more distal than probably expected. But we thought probably around here could be a good area to land a stent. But what is interesting especially is I remember when we discussed this case with Ebal that we had the doubt whether the ACS that this patient had came from a rupture from this nodule. Sometimes they can be associated with thrombus, or if this was just a secondary rise of troponin in the context of an infection. It looks like it is in the context of a patient with a critical stenosis. So we can move now to the... So we'll show you the orbital.
We can show you the device that we are going to use to perform a atherectomy in this case. As we mentioned before, it's an orbital atherectomy device. And perhaps, Emanuele and colleagues, what is worth showing to the people, if you show my hands, you will see the characteristics of this crown, which has, of course, is covered with. I think that
Can you move to Javier's hands and do
we
a lot of zoom?
Okay.
Yeah, you see the device. We want you to see
the device, yes.
first the crown. Yeah.
Okay. So this has the ability to perform sanding of the plaque antegradely and retrogradely. Then, if we go to the module that we're going to be using, and I'll have it here.
They haven't seen it yet. They haven't seen it yet.
It's a very important aspect of the system is that it is electrically powered, so it's very easy to use.
Can we focus on the hand of Javier? So
first do a zoom of the hands, and then we move to the...
Let's see the crown, Javier, on your hand. Zoom more if you can. Yes. Coming.
I think you can see it now.
Yeah, we see it now.
As you can see, it's very soft. Yeah? It's very soft.
This
now,
dark, Javier, this dark segment of it is the crown, right? What we see there.
Exactly.
Yeah.
And you can see that there is a fluid, a saline with a lubricating fluid here.
Is this white egg that is coming out?
And olive oil,
yes.
I think.
Yes.
So olive oil, okay.
Yeah, I know it is lunchtime, but yeah. So I'm going to show you the module that you use to advance the crown. Very simple. It has a brake that you can put in and out like this. It will immediately hold your wire, okay?
Yeah.
It has a knob that you can use to advance and to bring back your system. We're going to position it now in this location and we are going to lock it. You have a modality that allows you, it's called glide assist, that will allow you to go to low speed, similar to what people know as Dynaglide in other systems, okay? And then you have two different speeds for rotation, 80,000 and 100,000 RPM, that will increase the 120, sorry, RPM, which increase the orbit of the bird. So remember, the bird has two ablative movements. One is on itself, and the other one is performing a big orbit.
Can we hear the sound, Javier? Because the sound is self-telling.
Absolutely. So
we're going to put it on the wire now, on the Viper wire.
Yeah.
One important thing about the fluid is that actually it's a question that you need to make every patient about the allergies.
Well, the measurements, the sound. So you will see it in a second. Nieves will help me here.
Mm-hmm.
By the way, congratulations for the operating table there. It's so clean. I never had such a clean operating field.
Thank you. Well, it is also our nursing team has to be praised for that.
Absolutely.
But it's true that we also try to be, as clean as possible. Okay, so I think that Nieves, this is a good place where we can now
we don't have the wire
test. The rotation of the wire is still not out. I will wait until you get the wire out.
Yeah, now.
Okay, you got it? You want to hold it?
Yep.
Hold the wire with the brake?
Yes.
Okay, and then we can try that. Go?
Yep.
Can you hear the sound?
We can. This is the which speed? The slow speed or the high speed?
This is 80,000.
80,000.
This is the low speed.
Yeah.
Okay.
Okay. So next thing is Nieves is going to help me with this. We are going to
going to glide assist.
I think that first we will introduce it in the catheter. We have to remove the brake.
Yes.
Nieves is holding the system. I'm just pressing fluoro to make sure that my wire stays in place.
Which kind of Y connector do you have, Javier? With the screw or with the valve?
Okay, so Nieves, I'm now leaving my hands out. Okay, so keep an eye on the wire. Okay. Okay, so I'm advancing now the crown. Yeah, no, it's okay. I will be with you in a second, Emanuele.
Sure.
Okay. So you could
stop.
You could now put the glide assist to advance, but actually, what I do is if it is running well, I just do it like that. Okay.
Stop it. Yeah, can you stop?
No, Nieves is holding the wire very nicely, and you of course make sure that. But there is no tension whatsoever. The wire is in a good location, by the way. We will pull it back in a second a bit, but it's in a. We tested before that it's in the right. Okay, so here's the crown. Probably you can see it. I'm going to make a bit of thickness so you can see it, and you can see that the crown now is very close to the left main. Okay. Good. And at that point is where
Can you show this?
We are going to do the following. I'm going to activate glide assist, okay, and I'm going to try to advance the whole system distal to this angulated. I have to of course not yes. to keep the brake off, and I'm going to try to cross it very carefully. So Nieves is going to play a very key important role here, because she must at the same time keep the wire in place, but also perhaps apply a bit of tension. Okay, so I'm going to do it now.
Yep.
Okay, activate. No? Okay, I'm in glide assist.
Okay.
Okay, Nieves is putting a bit of tension. And and I'm crossing. Okay, stop now. So I'm going to store this. So you've seen the whole man is put it in glide assist. Nieves applying a bit of tension. The crown points downwards, and then it crosses. It's very, very nice. And I must say that in this type of stenosis, nodular stenosis in the proximal circumflex, sometimes you overestimate the degree of luminal narrowing. To be honest, Nieves, of all the cases that we've done of ostial nodules, we have been able to cross without pre-dilation, something that personally I don't like to do with this technique, because it's much more effective in terms of ablation than orbital atherectomy. And therefore, I'm concerned that the bore may catch with any dissections that you create in the vessel. So personally, I prefer to make a fresh ablation.
Javier, I would like you to clarify one point, if you can, for us. At the variance with rotational atherectomy, where you would exert a forward ablation on the plaque, what you are trying to demonstrate here is that you would start with a backward ablation, right? That's the main difference.
Exactly.
And I think that perhaps you can show the second slide again for a second, so to make it clear for the colleagues. But with the second slide, we try to demonstrate that the advantage that you have by doing that is lots of safety. Because first, you are having much more control on the bird when you're bringing it back. Second, it's more effective because you are bringing, as you pull it back, you are bringing the crown towards the nodule, so you are making effective ablation. And the third one in this case is that I'm not going against the carina with this obtuse marginal, but I'm simply going backwards. So I don't think that Nieves and we will perform any antegrade ablation in this particular case. We will, on the contrary, as indicated at in the right panel, we will make just backward ablation. Okay. So we are ready for that. Emanuele, I'm going to show you now how we do the ablation. So the first thing is that Nieves is, as you say, pressing the brake. We are safe now. We are not in glide assist mode. And I now open the knob so I can make my backward sanding. Okay? I start...
we are a little bit distal,
probably
maybe.
What I do is I am a bit distal, Nieves.
Yes,
so I'm going to bring it back.
More proximal,
I put it in glide assist. And you... I do it.
Maybe a bit more proximal,
I think I'm happy with that.
There,
what do you think?
This is fine,
So we now brake is on.
Let me put we are in glide assist, so I'm going to change again to the
ablation.
And we are
and
the
now
brake.
Look at my hands, because it's entirely different technique than rotational atherectomy. This is very important. Look at the speed I'm making the backward sanding. Okay, I start sanding now. You can hear the sound, and look to the speed. I keep hearing. You probably barely see my hands moving. Time to time, I release, so I do not have tension. Okay. And I have a signal now that tells me that probably it's a good time to stop. So I have adjusted my ablation to the time needed to reach the left main. Okay.
I have the impression that the guide wire came back a little bit, or is it?
Okay. So in that case, what you need to do is the following. You remove the brake. You put glide assist.
Glide assist again.
Okay. And now I activate the system and move the wire forward. You see? And now I stop.
Okay.
So that's the way that you. Nieves, I think, as agreed, we are going to perform more ablation, but always backwards.
Only
okay?
backwards,
So,
yeah. So
so
let's repeat it to advance, yeah.
Yeah. So let's go for glide assist. And you need to help me again to cross this angle, okay?
Yeah.
Okay.
So I'm holding the wire with a little bit of tension.
Okay.
It went already much more easily.
Yeah.
You saw? Yeah.
Okay, so we go now for another ablation. We put the brake on. I'm going to make it with scene so you can see a bit. You can see how it's moving. But
Yes.
look at the speed. No pecking movement. Sometimes you see these small jumps, and then you release the tension, okay? And you will continue with fluoro so we don't give additional radiation. Okay. Happy with that. And probably Nieves a third. I would not, in this particular situation, I would not go to 120,000.
No.
I think I will stick to 80,000. I think that's probably the best. Okay? Patient is doing very well. The hemodynamics, we can see the EKG is perfect. Patient is not having symptoms. Again, we go to glide assist.
Javier, in your experience, do you also happen to have this transient AV block with orbital atherectomy?
Sorry,
Oops.
be careful.
Sorry.
Yeah.
Manuel.
We haven't had it,
No.
Manuele. No.
No, but beyond this case, does it occur at times?
No, we didn't have in any case with orbital atherectomy AV block.
I'm just repositioning, keeping the wire in place, and making sure that I'm bringing it to the place I want to start doing ablation. Okay,
maybe
so
last one, no?
Last ablation before we assess what happened, yes. Eh?
Yeah.
Okay. Okay. Good. So, Nieves, if you agree, we have completed this. We are going to put it in glide assist, at least for the initial part of it, and you bring it back.
Yes.
I will just. Now is your job, okay?
Yeah. You started.
Okay. You know, from this point, probably you can. I stop glide assist because it prevents also the losing the wire, or you don't need. Everything is running good.
Okay, Javier,
So,
while you're
Emmanuel,
doing
any
this
questions?
maneuver, I assume you are going to do a run of imaging now?
Yes.
Okay.
Yeah. First thing we're gonna do now is change this wire and protect the branches.
Okay.
That's the next thing.
Let me just get the opportunity to get some questions from the chat box. Ewald.
Yeah, there's some questions, technical questions here. What wire are you using, and did you bring it down with a microcatheter, or did you wire it directly? This is one question. And can you explain your criteria for going from low speed to high speed?
Okay, I think the first question is interesting. You already told us that you cross with the Sium and then you exchange over the microcatheter. Perhaps can you tell us more about this Viper wire? Is it hydrophilic? Is it a good performing wire?
It's a 19 wire which has superb steerability, and it's not a kinkable wire as well. So that's something that is very advantageous. And I'm sure you know, Emanuele, if you can comment, you can ask also some of the colleagues in the panel who are experienced with the technique, and they can give you additional information.
Sure. Perhaps we can share with the colleagues when would we go from the low speed to the high speed. In this case, the colleagues we're happy with the low speed. I don't know if anyone can take this, Peter.
That's a really good question. I mean, for me, the tortuosity and angulation here I would stick with what the guys in Madrid are doing, which is a fantastic job, and stick with low speed, because I just think you possibly need the high speed in terms of efficacy, and I think the safety margins probably start to change when you go to the higher speed. So I would do exactly what they've done. What I really liked about what they've done, just to pinpoint, was they had the advancing device set in the middle, so they could do the bidirectional right from the get-go, which is very different to how you might set up if you were using rotational atherectomy. So really nice demonstration.
I noticed in this case that we have two important branches in between there. We have the LAD and the big marginal branch. The OCT pullback was very illustrative there of the bunch of calcium, this calcified nodule that was almost protruding into this marginal branch. How is it orbital atherectomy in terms of risk of jeopardizing the side branches?
In my opinion, and that's why I would have maybe done it a bit differently in my practice, this just the backwards orbital atherectomy moves, I don't, because if it's differential cutting and if it's about removal and debulking, and this is, I think, the purpose of doing this, I would not be reluctant also on doing it on the forward bay, because I think at the end I want the least calcium possible. Of course, when you come back, you are on the proper side, but even removing some calcium from the other side is fine. I don't think it will jeopardize the vessel.
Okay. I think now the colleagues are exchanging their guide where the Viper wire is out.
Yeah, we're putting up.
Yeah, we're doing a trap-in to change.
So just putting a trap-in balloon
macro
to get it.
Yeah. Perhaps when you are at your ease, Nieves and Javier, you are highly experienced with this tool. What is actually the chance of side branch jeopardization when using orbital atherectomy? Can we safely do this procedure?
I would say that similarly to rotational atherectomy, very low. I think that in general, it's a very safe technique for that. What would you say, Nieves? The possibility when you are performing atherectomy, the chances of losing a side branch. Okay.
Yeah, well, I mean, I would say it's probably similar to what happens with other atherectomy techniques. I think in general it's not the moment of high risk of losing the side branch.
Okay.
When you perform the atherectomy.
And I guess you had a good point only to do backward orbital atherectomy. You explained us. Was there any gain in doing this also forward?
Imaginar cómo están las ramas. Yes. Yeah. Sorry, Emanuele. We were discussing the next step because probably it's a good idea to.
So we'll make an injection.
To make an injection and see.
Okay.
See how are all the branches. Patient has some chest pain, and we wanted to check how is the vessel.
Okay. No worries.
Okay. Oh. Okay. So the vessel is at this point is a bit occluded, and what we're going to do is before doing OCT,
give me a balloon.
We are going to perform a balloon dilation, and also to give some nitrates.
So we certainly did some plaque modification there. So we need to get it back.
El balón de 3.
Yeah. Un balón de 2,5.
Está en la mesa.
Nitro, por favor.
El balón.
So we will give a bit of nitro just to make sure that the side branch is well preserved. So
that's a question for the panel here while they are working.
Nieves can comment on the
just go on. Javier, we'll try to discuss some points here in the panel.
Because the audience would like to know what is the difference between high and low speed.
Yeah, what is actually the effect on the plaque in terms of modification? Is there any specific anatomic setting where you would say, you know what, I'm going high speed?
Well, I think at the higher speed, you're increasing the radius. The crown is orbiting, so your penetration into the tissue will be deeper. I also think because you're going at a higher speed, your effect on hitting the vessel, hitting the calcium, will be harder. So you're getting sort of two penetration. You're getting this extra sanding deeper penetration and perhaps more fracturing ability. In a large vessel, potentially straight vessel, where you've got more concentric calcium, I think it's a good idea, the higher speed. My fear sometimes if you've got more eccentric calcium is that there's a higher risk of perforation because it will differentially damage the normal side of the vessel, which could be potentially slightly weaker. So I think erring on the side of caution and sticking with low speed is usually safer.
And just to come back to the point of Florin before, when would you do backward and forward orbital atherectomy?
The advantage, I think, of going retrograde with the crown is that you avoid that jumping of the crown forward where you're sometimes pushing against harder material if there's a more severe lesion where there's a resistance to kind of crossing. So I think in that way, if you can glide assist across, it's actually easier to go backward first. I think I possibly would still go forward having gone backward because I might want to do 5 or 6 runs, and I don't think there's a huge disadvantage in that respect.
Okay, I think the situation is back under control. You pre-dilated.
Yeah, I mean, you probably noticed that as soon as I did some daughter effect, there was already flow. So
yeah, it's a lot of disruption.
Before performing post-dilation, I just crossed with the balloon, bring it back, perform a small ejection, and there was flow already. So what I'm going to do now, before continuing any further, is just making sure that we place a wire now, what I'm doing here is a recommendation for the fellows. Never leave a wire with a knuckle that is going to be jailed. And that's the reason because I brought it back. Because otherwise, if you jail a wire with a knuckle, you may have a big problem later. Can I have a small injection?
Eso es la vea, ¿no?
And get an entrapment that is very difficult.
So I assume the chest pain is improved, right? For the patient?
Yeah, he's better. He's much better, yeah.
So let's make a scene, if you wish. It was patent. It was
all patent. Let's put the wire in the marginal, and so we have all the wires in place.
Yeah.
And then.
So then, did you make a bend in any of the wires?
I guess, Florim, this is
not yet.
Nothing surprisingly. I mean, it can happen in this kind of procedure that we might have some slow
this
flow,
is the LAD and
which is partly explainable perhaps by the effect of the ablation there. We might have some...
Oh, yes. This is not entirely unusual when you are doing, atherectomy in patients that have extensive disease, etc. Something that...
Yeah, I mean,
you have to be ready to handle and no rush. Perhaps the most important safety test is to make sure that you do not have a perforation that is fortunately is not frequent, but it's probably the most important. I will say safety tests.
Yeah, the disruption of these nodules that are so occlusive. Once they get disrupted, sometimes they get even more into the lumen. We see this with OCT. Sometimes when you when you modify them, you can see them even more coming into the lumen. So I think it was probably more related with that, but we're gonna see.
We'll check.
So now the plan is...
I think it's important now to...
OCT, and then we decide what to do next.
Yeah,
exactly.
And so another safety maneuver we are going to do, Emanuele, is to perform a dilation with a 3.0 balloon.
Which was the balloon? The balloon you used. Which was the size?
3.0.
3.0.
It was a 3.0, the one that you gave me?
Yes.
Okay. But
it was already. So we already pre-dilated.
Okay.
With a 3.0. Yeah.
So let's have a look to the effect of orbital atherectomy and of course balloon angioplasty now. We also have performed subdilation, but we want to see if we have prepared the plaque properly. Good. So Nieves, you want to guide us on what you are doing with the
so let's make now any pullback. So first thing we need to check if we are engaged
very
properly
important.
With the catheter. It looks like we are. We have adjusted our contrast, is 415, and now the system is gonna calibrate, and we are gonna acquire angio at the same time to have co-registration. Okay, there is some interesting image also in the distal marginal that was not present before. That we also need to check. Distal to this branch. Oh no, it was there already actually. Yeah. It's now probably a little bit of spasm also there.
No, we're fine.
So we're gonna co-register. You can see that this is really fast with OCT.
I'm proceeding now to take out the...
Even in a tortuous vessel, but the system is quite good. You can always edit it anyway.
Yeah,
oh, the wire came out.
I'm afraid that the wire came out, yeah, okay.
If we go back to the, so you remember that we had in the initial pullback assessed this as the possible potential distal landing zone.
Yeah, can we
and
keep
you
the
remember that
OCT?
There was this,
can we keep
OCT
the OCT on the big screen?
OCT in big?
Yeah, this is what we're interested in now.
So you remember we had chosen an area around here for distal landing that is around 3. And you remember also these areas with a lot of calcium that we saw before. They look already different. You can see the disruptions of the big chunk of calcium that we were seeing before. We are approaching now the area of where we have more stenosis. So you can see this was the region where the nodule started. You can see it there. And I think you can appreciate there is actually some disruption of the nodule that is visible in different places. For example, there you can see it at 9. With orbital, you don't see usually this effect of fractures, lineal fractures that you see, for example, with IVL. You see more kind of disruption. And I was mentioning before, you can see that the nodule is now protruding even more into the lumen because it's kind of disconnected, let's say, from the shoulder. So sometimes they protrude even more after modifying them. And here we're back in the left main with the images we saw before. So really, I think we have achieved quite a good degree of modification of this nodule. You remember that it looked very homogeneous before, and now it looks much more irregular in the surface, suggesting that this has been touched by the orbital device and modified.
By the way, we are also appreciating the AI-facilitated assessment of this vessel, segment of vessel. We see a diameter there, an MLA. Are you already thinking to the stent to place here?
Yeah, this is also an interesting aspect. You can see that when we activate the system here, the system is telling you where is the calcium, is the orange line. So you can see, for example, here, big chunk of calcium that is 180. The system is also telling you about the thickness of the calcium, and this dotted line that you can see is telling you, indicating you the EL in the area where the system is able to recognize the EL. You can see at the other side of the vessel is not able to recognize the EL because there is a lot of calcium, very thick. You can see the thickness of the calcium is 1.3, so really thick calcium at this level. So I think based on this we can probably move to recheck the sizing we have done before. And this is the distal landing we have decided. For the left main, we thought it was really not needed to go to the very ostial part of the left main, that we could keep it with, without, I mean, maybe in the mid part of the left main, so an area around here, for example. So probably the idea is to cover this with 333 millimeter stent. We're going to pre-dilate a little bit more because in the previous pre-dilation we didn't have a wire in the LAD, so we didn't want to pre-dilate much, just the ostial part. And we are gonna we were just pre-dilating a little bit more in the circ to recover flow, and now we're going to pre-dilate a little bit more.
This is a small trick for interventionalists in the room, more than 50 years old. You focus to my hands. You can see how I managed to put a wire. Can you focus to my hands? This is how I put wires into my things. I just use the half of the syringe to put the wire directly into my.
So it's a trick balloon. Not for seniors, so not for fellows, but for seniors.
We have a set of teaching points for fellows and for next generation, meaning
next gen,
people that are like me. Okay. So,
Ewald.
Yeah. That's a question from the audience. Do you think there's consideration for the stent expansion capacity? Should you split it into 2 different platforms to be able to expand it adequately in the left main?
You know, we measured the left main, and if we stick to the middle part of the left main, it's not such a huge left main. We can show you some measurements there, but you can see the lumen is around 3.5. So and the vessel probably must be around 4. But so I think we can accommodate 3 millimeter stent, and you know it always facilitates. There are lots of branches in this circumflex, so it's always easier if we can use 1 stent.
Good.
You have seen the expansion of the balloon, which
Yes.
I think is also an interesting point.
I like this technique. Can you explain why you did that? This filming.
That is is rotational angiography. You do not need any special equipment. I just
But
did it in
why
Spain,
you did it?
like in many countries.
Yeah.
Oh, because you want to see that there is homogeneous expansion
Okay.
of the balloon in orthogonal
And also the
planes.
stent.
So you know, remember, it's a
Stent,
highly
yes,
eccentric
433.
lesion. It's a nodule, and you can see that the plaque preparation has been very good. The compliance of the lesion has been improved, and now what you have is that the balloon is opening nicely and evenly. Okay. Now, my suggestion is 1 injection to see that after this, say, dilation of
Un momento,
the
un segundito,
trifurcation,
no lo abras todavía.
we still have patency of the vessel, okay? So this is what we have. Yeah, and I think that no doubt that everything is patent, so we are happy. Eh?
Yeah.
Very nice, yeah.
Yeah.
Good, so let's go for the stent.
The marginal looks probably maybe a little bit more, the osteum looks a bit more pinched than it was before, but I think for this marginal, our objective is to keep it open. No?
Keep it
Yeah.
open.
So I think
Most likely could be
so
a
we're going to go
spasm.
with the stent.
Yeah.
If we need to do something, we can always do it
3.33.
later, you know.
Yeah. Javier,
Luckily,
can you anticipate your stenting strategy? Are you going to place 1 stent crossing over left main circ? Provisional? That's your
Yeah.
strategy?
No, the Nieves and I discussed, you know, that the best possible strategy will be to make crossover to stent. I mean, certainly is our standard practice in any osteal circumflex stenosis for many reasons. Because it is more effective, because it is safer for the future, you know, if anything has to be done, and because we do not believe it has any major intrinsic risks. I mean, it's, you know, it is not really left main PCI. You are not stretching a plaque in the left main. Well, perhaps in this case a bit, yeah. But it's worth, we believe, performing this. It may take you a few extra minutes because you have to perform, of course. So this is it's the stent. Sorry. Yeah.
This is a stent. Yeah.
I typically, this is something that we insist a lot is, you know, rule of thumb for safety, but still many times forgotten. We always cross the stents detached from the deflator. And that is how actually the booklets that come with the stent tells you have to do it, okay? And only now is when we connect the deflator to minimize the possibility that there was any mishandling or whatever contributing to detachment of the stent from the balloon. So, Emanuele, sorry for sharing these very basic things, but you know, it's EuroPCR. We know that there are a lot of young colleagues with us, and I think that these are important topics. Eh?
I'm watching through the room here. I see indeed lots of young colleagues here. But
so, Nieves, probably a bit more
inside,
into
yeah.
vessel, yeah?
We thought we were not going to go really to the osteon of the left main.
Okay.
What is the final size? What is the size you chose? It's a 3, yeah?
3.33, yes.
3.33.
Yes.
I suspect it's a stent that starts with an X, the name.
Okay.
Exactly.
Yeah.
Yeah. It's exactly the
You can
stent
imagine
with an
it's
X.
it's a science, yeah, exactly.
Go for it. So no knuckles in the wires. The only
And you
knuckle
can
that you
see,
have is in the very.
So I'm not going to go super high pressure here because you can see that there was also some disease there. So we can implant it here, and then now we bring it a little bit more proximal. It's safe because the proximal left main is very, very big. And then we can go a little bit more pressure. And of course do the pot.
Probably you can comment on the deployment.
Yeah, it's very useful, this feature of Ultreon. So you can, once you have decided your landing zones, really the system offers you the possibility of co-registering it with angio and really help you to position adequately your devices. So I'm going now higher pressure, and we can now do POT. Yeah. So we were about the POT balloon. We were deciding if we were going 3.5 or 4. I think both options are okay. If you look at the OCT images again and the size of the left main.
So of course, in this case, Peter, I don't think there is a major risk of balloon injury proximally. It's a 3.5, 4 millimeter left main with a 3 millimeter balloon. When they did this maneuver, I don't think there is a major issue there, right?
I think that's right. I mean, I'd probably take a 4.0 because I think it's 4.0.
But
I wouldn't be too concerned. I mean, they've obviously made a good choice in the stent.
So what is the next step? A POT?
So we're going to POT,
we are doing POT with a 4.0 balloon.
4.0.
We will
and you leave the wires in place, still jailed?
Of course.
Yeah. We're going to leave them in place.
You know, Emanuele, when you have a lot of calcium, my concern regarding the side branches is that the carina gets displaced towards the calcium. That is very tricky if you have an occlusion of the vessel to re-enter. But in this case, if the carina in the obtuse marginal was displaced and we have occlusion of that vessel, remember that we know from OCT and also from CT angiography that there is no calcium there. So that's we will have chances, to recross with another wire and to perform, of course, side branch dilation. But I think that is an important message, I believe, in bifurcations with calcium. Always think, what is going to happen if you displace the carina? Will it be against a block of calcium? Then an occlusion can be very difficult. And in that situation, I rather prefer to perform kissing balloon dilation from the very beginning.
I also noticed, Javier, that you resisted from the temptation to do an angio control. That's what many of us would do after having placed the stent, just to make sure that we didn't have plaque shift. But I guess you rely upon the findings you just mentioned and the patient's symptoms. Now the patient is okay, so you don't anticipate anything wrong.
Yeah, exactly. I mean, as you know, Nieves and I, we champion about the importance of reducing operator dependence on contrast opacification, what we call ultra-low contrast PCI. And this is something that we apply routinely in all our cases, I will say. But with that, of course, this is also a typical scenario where you see that the balloon is not advancing well. And you have to be very careful because you can distort the stent. So what Nieves is going to do...
When it happens to me, Javier, I ask to my fellow, did you place the balloon on the right wire? How do you make sure this?
Okay. Well, it's a question for Nieves, but...
Nieves, have a check on the wires.
I think I did. Okay, I think I did. So we have the wires when it's...
Good.
But
could happen,
certainly we will recheck, Emanuele. Let me see.
So we had the...
Dame el que está doblado, por favor, es este, ¿verdad?
Sí.
No, I just want to reposition these wires a bit.
So what we do usually is use different colors if we can, blue and green. And then in this case we have two Sions, so one of them, the one in the branch. Usually we fold it.
Stem boost, please. Stem boost.
Just to, as a trick, to distinguish them. But there's something very important.
Stem boost aquí. Y ellos lo pondrán también.
Espera un segundo, que hay que ponerlo en rayos. Live, yeah.
Okay. So let me just make this soon.
So we're making now a stem boost, just to.
It's not too bad, Nieves.
I'm gonna make a test with.
I think a bit more proximal, to be honest, but it's not too bad for a pot.
Well, let's do some contrast.
Let me also look for the orthogonal projection because this is important. This is more orthogonal, I think. This is more orthogonal. Let me just check again. No,
looks like you're out, no?
Yeah.
You moved a little bit out. We can give some contrast here now to also understand the position with. Yeah.
Yeah. Okay. I'm happy with this.
Yeah. Okay. So I'm gonna now to the pot. We don't need really to go high pressure here because there is not. The thing is only opposing the stent to the left main.
Y pásame otra guía, por favor, otra guiación.
This is a semi-compliant or non-compliant?
It's an NC track balloon.
NC.
So we are bringing a fourth
Next
wire.
step is rewiring the LED. To perform a kissing. You saw in the last injection that it looks like everything was patent, all the branches. So
yes, thank you very
looks
much.
like,
I know
yeah.
you did it for me, otherwise you would have done it. So Peter, what do we do here? Kissing LED, sir, kissing OM, sir, kissing everywhere?
That's a great question. I mean, I think we don't know the answer. I think if you're going to kiss, I think understanding the wire placement with OCT guidance is essential, because we know inadvertent kiss with the wrong cell in the wrong place actually could harm the bifurcation, particularly when you've got calcium. And in that situation, I think when the trials are done with angiographic guided wire placement, I think that's why they're always neutral, because half the time it's probably in the wrong place. I think if you OCT guide the wire and it's in a favorable position and you've got obstruction of flow in the LAD with a cell across, then I think it's reasonable to kiss, but I would use the OCT to guide it.
Do you think we are so good in telling the wire exactly what the wire should do, or sometimes we can just control it?
I find that a bit difficult. I think it's important. I mean, I would like to see imaging now, because the most important thing and why we did this PCI was to achieve an optimal stent expansion in that ostial circumflex. So I would like to see a nice MSA there. If I see that, then I would depend the rest of my steps on the angiographic appearance of the LAD, especially because the marginal just needs to flow, and the LAD should not be too pinched. If the LAD is pinched, then I would kiss. If the LAD is not pinched and it has a TIMI3 flow patient is spine, I would end the procedure with an optimal stent expansion at the ostium and an opposed stent in the left main.
So you would even consider not to do kissing by default towards the LAD?
No. Because why?
Well, I don't know if Thierry Lefebvre is in the room. He might address this.
You could do maybe a survey. Who would kiss?
Yeah, that's a good point. If we can have a light in the room, who would do kissing balloon LAD circ irrespective of the OCT finding? Raise hands. Who would consider not to do kissing if, like Florim said, the result is okay towards the two branches?
Hay que sacar la otra.
What do you
La que
think?
está doblada, ¿no? Esta.
60-40. So there is still motivation to kiss.
Well, I think it depends a lot on the vessel, no? But this is left main, and this is the LAD. So keeping access to it, I mean, looks like a good option, I think, for the future of the patient. You could have good access with a good pot, and I guess that's the opposite view, but let's see.
So the bended wire now nearest is circumflex. Okay.
Okay. So yeah, so we're gonna.
Perhaps, Evald, what is your attitude in this situation?
We are going to do
I think one way to do it is to rewire the LAD before you do the OCT and you do the angio, and then if you need the kiss, you can also see if you have got the right window towards the LAD. This is a way to spare the contrast and get all the information. And I would also do a distal optimization, and I would also put the obtuse margin with 3.5. I would put the obtuse margin with 3.5, and I would post-dilate with 3.0 non-compliant balloon distally before I did that OCT to get all the information before I use the contrast.
Yeah, in the diagonal branch. Yeah. Yeah. This wire is a bit damaged, I think. Yeah, I think there is probably room for optimization in the circumflex. Yeah.
Perhaps we can go through some of the questions in the chat box, Evald.
Yeah, this is a little outside this case, but there's something about drug-eluting balloons in the LAD. If treatment is needed after, I think it's a little outside the scope of the circ treatment in this case.
Yeah, but I don't think Florim wants to miss the opportunity to address this question.
Because we discussed this actually yesterday, and I promised not to mention it up front, but thank you for the audience. I mean, I think we don't have really clear data to support one strategy or the other. In my opinion, and I know I'm less experienced than all the rest of the panelists here, but in my opinion, I think if you can avoid a stent in an ostial circumflex which is heavily calcified, that's not a bad idea. And if you can create lumen without creating a bit dissection, and avoid a stent, yeah, then I do it. I like to do it. But I think we need prospective randomized data to answer this question. I cannot propagate it for everyone, but that's my opinion.
But I guess the colleague wanted also to know about, at this stage, with a stent towards the circ, does it make sense to do DEB as a balloon strategy towards the LAD, left main LAD?
Absolutely. I think if you balloon the LAD, then probably you should also consider D being the LAD. Yeah. If you don't balloon the LAD, then you might as well just end up just with one stent towards the circ and leave the rest. I was speaking about DB of the ostium of the circumflex.
Okay.
But I think, if I may add, two stent strategies in the left main, this has proven not to be a good strategy. So I think to avoid two stents is always a good thing if you can. Sometimes you just cannot.
Sure.
Sorry, I'm speaking Spanish at the same time here.
So
talking about the sizes of the balloons for the kissing.
We did not want to interfere there. I mean, when you want...
Yeah, no, what they did, it's a very nice example. I mean, what they did is the wire got knuckled. And what I did is, because I was already about to cross the left stent towards the LAD, I just completed crossing, then brought the wire inside the balloon and then advanced it again. It's in a big diagonal. We are not going to struggle to put it in the true LAD because with this distortion of the distal part is okay. But for what we want to do now is we believe is more than enough. So that's basically what you were probably seeing while we were following your nice discussion. Now, of course, what we are preparing is just a kissing. We will do this guided with a stem boost.
Evald, anything else?
Yeah, there's a question from the audience about the demonstration of the distal rewiring of the LAD before the kiss.
Okay, let's first understand which balloon are they using in Madrid.
So we have a 2.5 in the LAD and a 3.0 in the... We're going to put a 3.0 in the circ.
What was the question, Emanuele? Sorry.
About the
balloon size that you're using.
Yes.
So we are planning to use a 3. So we place it in the circumflex and then 2.5 to open the cells of the LAD.
And then the question was about the wiring technique. Exactly what was the question?
That was the OCT confirmation of the distal rewiring of the LAD before doing the kiss.
Yeah, well, it's something...
We did not do it.
No.
Yeah.
We have done it in many occasions, but in this particular case, we thought that on angiographic grounds, we were doing it quite all right. I don't know if everyone does, ensures with imaging that you are crossing through the right cell, but in this particular case, we did not think it was crucial.
Yeah, well, let me ask in the room here, how many of you would image the wire position into the side branch in this situation? Raise your hand if you would like to image this. How many of you would just see where the wire goes and try to trust the position? Raise hands. Yeah. I think I agree with most of you. Sorry, Peter.
I've been Octobered.
Yeah, the thing is, I mean, of course it depends, no? But it's in a case where you have done some runs in the middle to check calcium modification, some runs. I mean, I think it has to be a balance. No? You need to decide when is the most important moment to use it, because I don't think, in general, you can do lots of runs. Definitely, if we have any doubt about the position of the wire, we would do it, of course.
Yeah.
But
so
the interesting thing is that in bringing this second balloon, I'm noticing some obstacle that is very far away from the coronary arteries. So
there might be some crisscross of wires.
Yeah, it could be, you know.
Yeah.
It may happen. We try, of course, to keep it, but here it is, yeah. Well.
Do you think at this point...
We can change.
Yeah. Well, you
can change the wire in the LED.
You do what you need to do. Do you think at this point we need to have 3 wires in positions there? When it gets so crisscrossed, can we get rid of the wire of the OM and just focus on the essentials here, LED and circ? What do you think, Peter?
Yeah, the problem with the OM is that it's the one that has disease, no? So you're a bit, and it's not going to be kissed. So yeah, it's actually one where you, one situation where you would like to have it there. But I agree that sometimes it's really, you know, sometimes when you have so many wires, there's a lot of interference, and it really makes very difficult the crossing of balloons, etc.
¿Es pequeño?
Okay.
Yo creo que cambiar la guía de la DEA. Cambia la guía de la DEA. Ya.
Dame un check pequeño. You know, alternatively, what we can do is to perform
opening simple
side
opening
side pot. Side pod.
Good.
Okay. Give me a small test, Nieves.
It's a bit more proximal.
So without interfering too much, I need to give a feedback from the room. We can stay till the end. We were supposed to wrap up at this stage, but we can stay. We still have good 10 minutes. So we like to follow you, and
okay.
I think it's interesting to see how this case will end. I think in this situation, we know how to perform the technique. We know pot, repot, kissing, and so forth. We need to be pragmatic here. We need to warrant good patency of the vessel, safety of the patient. I don't mind what they're doing, honestly. If they have to do sequential ballooning, it's okay. At the end, we know the stent might not be perfectly... the geometry might be a bit distorted, but what can we accept? How much can we compromise? What do you think?
Well, actually, I think the bench modeling for the kind of side pot technique actually is pretty good. It looks, you know, if you do it well, as they're about to do, then I think it's almost as good as kissing. I think it's sometimes hard to predict, and I think, you know, what we hope we'll get time to see is that final OCT image, and we'll see, you know, how much eccentricity there is, and if there's any unintended, you know, deformation. Be really interesting.
And just concentrate on LED and circ.
Now they fenestrated the LED with a big balloon, so now you should kiss. Now you cannot end with this. If you took a small balloon to fenestrate the LED, then you can have still said, okay, fine. But with a bigger balloon, probably you would end up doing the kiss. And of course, as Javier mentioned, I think the accessing that marginal branch is still not a very difficult task, even if it's more pinched or occluded. They are very skilled operators. I'm sure they would achieve to do that. Most probably will stay open. It will just be a bit more pinched. And then you should accept it pinched if it's TB3 flow, because it's a trifurcation. You can't have a perfect result here.
Sure.
So, can I make a comment?
Of course.
Yeah. I fully agree with with the idea of using imaging. Hopefully we have convinced you that we do a lot of imaging, invasive and non-invasive. But, you know, I'm a CT operator. And in CT operators, we use a term that is called do not stay in failure mode. So we first try to do exactly what Florin was suggesting, make kissing. But if for whatever reason you start finding obstacles for that, you need to reconsider the strategy and to assess whether, you know, insisting in a particular strategy may bound to have more problems. You have to really put in perspective the benefit of being more aggressive, changing, etc., or changing to another strategy that is frequently performed, that is dilating, as you see, the first the LAD and then the circumflex. And you can see, and the leafman, and as you can see, it has certainly facilitated. We did an injection to make sure that the obtuse marginal was open, and now we are not having just going for OCT. So let's see what happens.
Yeah, I think one thing about imaging that is important is do it at the right time. So when you really need it, and it's going to change what you're going to do, because we were going to open this LAD anyway, so I don't think there was a reason to do OCT in the middle. It wouldn't have impacted our decision to try to open the struts towards this LAD. So each one has different practice, of course, and just use it when
this is LAD.
It's the LAD, yeah.
You want to make a run now? Okay, let's put it in the right
yeah.
way.
No, I think it's important to use it when you think it's going to give you the information you need in the moment. So I think now we need to understand if we have proper expansion of the stent in the circ and in the left main, and if we need to optimize, and that's the moment for me to use it, and after that optimize based on what we find. Probably we will need some post-dilation in the circ.
So by the way, this OCT catheter is amazing. I think we have a cross here near us. Okay, we need to be careful with this. Can you hold the wire in this from there? Okay. It's amazing. I mean, you notice that is the new generation of OCT wires and has the possibility of crossing in a much better way than previous generations.
Yeah, it's a huge difference with Opstar. Yeah.
So here we go.
Also in terms of durability, we have done a few bullbacks already, and it's perfectly.
So let's
working.
have a look to this next. Okay.
Ponemos 415 otra vez. The guiding is fine.
Yeah.
Yeah. Okay. Let's go to OCT full screen then.
Okay. Good. Ready?
¿Está bien el catéter?
Check.
This injection is by hand or with a pump?
Let me clean a little bit the OCT catheter.
Okay.
Sorry, we didn't get it. Is it with the pump or by hand?
It's powered injector.
Powered injection,
Yeah.
okay.
And we're going to do it in automatic now.
Okay.
Sorry, the system, yeah. No. So it's calibrating. No.
I use hand injections a lot, and then you end up using a bit less contrast. Because with the pump, the images are a bit more beautiful, but you use more contrast, of course.
Okay. I suggest, Nieves, that you would make your final comments on this OCT pullback, and then we come back here in Paris to close the session thereafter. Because we are left with 4 minutes.
So let's just perform the co-registration with Angio, and we can see basically what we're going to look for in this pullback now is if we have an adequate expansion of the stent, if we have problems at the edges. So here we start in distal edge of the stent. So it looked like we landed in an appropriate place. There is no edge dissection.
So number one, no edge dissection. Good news.
No distal edge dissection.
Okay. Number two, stent expansion.
Yeah, exactly. So we're moving along the stent, and we will give you some numbers, but about the expansion. But to me, in a general initial view, without just a qualitative assessment, it looks quite okay. Let's go to the more critical area, which is the one of interest.
Yeah.
And here you can see what happens often with these situations is that the lumen is so irregular, the shape, that you get areas where it's impossible for the stent to be completely opposed, because the lumen is absolutely irregular. For sure, I think we have some room for some post-dilation in this.
Okay. If you
try
can
to
go
open a little
quickly
bit
back
more
to
here.
the left main, Nieves, because we're almost running out of time.
Yeah, exactly. Yeah, so this is the left main, and here again, it looks like we really need to post-dilate more with a 3.5 balloon, all the proximal circumflex into the left main.
Why don't
this
we
is
go
the
back?
left main that looks good.
Yeah. Why don't we go back on the full screen on both operators, just to conclude with you the case, Javier Nieves, and then you will move on with the case on your own.
Let me show you an angiogram just to
Yes,
with
please.
some nitro, so you can see the result.
Fluoro, please. Yeah.
So as you can see, we still have patent obtuse marginal.
Good.
Probably we will leave it, Nieves. You can see that with nitro, compared with OCT, things have improved also in that small branch where the wire is.
In 2 words, Javier, what are you going to still do after this connection, with this live
We will
connection?
post-dilate a little bit.
Yeah, very simple. Just you know, inflate the balloon, not to treat any lesion, just to make sure that the stent at the point that you were saying is fully opposed. But that's it. I mean, we can say that the case has been concluded.
Yeah.
And hopefully has delivered some interesting messages. As always, we ourselves have also learned with this case.
Thank you very much. Thank you very much, and see you soon back in Paris.
Bye, thank you.
It was a challenging case. This is something we expected, but I think that all in all, they did what they had in mind. That was their preconceived strategy. Of course, they will post-dilate, but the good take-home message was orbital atherectomy did it well, imaging was useful. I hope you enjoyed this session as much as we do, and have a good afternoon. Bye.
Thank you so much.
Thank you.
Thank you.